Hello, welcome to Crush My Dental Boards. Our topic for today is local anesthetics used in dentistry. So what are local anesthetics? Local anesthetics are basically the numbing agents that we use to relieve patients of pain that we can cause them while doing our procedures, or pain that they originally came with when they entered our office. Now, how do local anesthetics work? We know that local anesthetics work by reversibly blocking sodium ion channels and so preventing depolarization of nerves, which also means, blocking of action potential. Now, one important thing that we have to take note in this mechanism of action is that local anesthetics should work in a reversible manner, meaning the numbing should wear off after some time. Okay, so this is not permanent blocking of sodium ion channels, but it is temporary or reversible blocking of sodium ion channels. Now, local anesthetics target nerves. However, sensory nerves are more responsive to local anesthetics compared to motor nerves. Local anesthetics are not meant to be injected into blood vessels. So this is the reason why we aspirate even before we deposit the local anesthetic in an area. Okay, so the target are sensory nerves and motor nerves, but sensory nerves are more sensitive to local anesthetics compared to the motor nerves. Now, the susceptibility of nerve fibers to local anesthetic is as follows. Small diameter fibers, right here, are more sensitive compared to large diameter fibers. And myelinated fibers are more sensitive compared to unmyelinated fibers. So what does that mean? It means that if you have small myelinated fibers, they get numb easily compared to your large unmyelinated fibers. Okay? Now, the order of sensation disappearance and reappearance when local anesthetics are injected in the area would be the following. So, first thing that disappears would be pain, and then the second one would be temperature, the third one would be touch, and then the last one to disappear would be pressure. If you placed a good amount of local anesthetics, then even pressure would disappear. Okay, but with just sufficient amount, then this is the order of disappearance: pain, temperature, touch, and then pressure. Now, as to the order of reappearance, pressure reappears first, and then followed by touch, and then temperature, and then pain. So the arrow goes the other way as the local anesthetic wears off. Now, some basic things about local anesthetics. First, local anesthetics are considered weak bases. Okay, so they are more basic. However, they're weak bases. What does that mean? It means that the pH of local anesthetics is somewhere between pH of 3.4 to 6.5. So local anesthetics are considered weak bases in an aqueous environment. So aqueous, we all know aqueous would mean like water. Now, local anesthetics consists of a mix of ionized, which is charged, kaya sinabing ionized, and unionized molecules, which are negatively or uncharged molecules. Now, between the two, ionized and unionized molecules, it is the unionized molecules that are needed because they are the ones that are capable of crossing nerve membranes, and they do so by passive diffusion, and they are the ones that bind to your sodium ion channels. Again, local anesthetics are a mixture of ionized and unionized molecules. It's the unionized molecules, or the negatively charged molecules, that are able to cross your nerve fibers and bind to your sodium channels. Okay? Now, in general, when we talk about local anesthetics, the solution itself has a lower pH compared to normal tissue. Okay, so normal tissue pH is 7.4. That's what makes local anesthetics work The solution inside a cartridge or a carpule has a lower pH compared to normal tissue, which has a pH of 7.4. However, in the presence of infection, in the presence of an infected tissue, what happens is there's like a role reversal. So in the presence of infection, tissue actually becomes acidic. So the local anesthetics are less effective. That's why, when we encounter a patient with a big infection, we would usually tell them that the anesthetics might not work. Why? Because in the presence of infection, the tissue pH becomes acidic. So once the tissue pH becomes acidic, then the anesthetic will not work as effective. In the next slide, I'll be showing you what it means. I'll be explaining it in a more graphic manner. Okay? Now, another thing to consider when it comes to local anesthetics is that local anesthetics are vasodilators in general. Local anesthetics are vasodilators in general. The reason why there can be vasoconstriction because of local anesthetics is with the addition of your epinephrine or your levonorepinephrine. So these are the two agents that are added in the local anesthetics to give a vasoconstrictor effect. Now, what is the benefit of having vasoconstrictors? One, vasoconstrictors would reduce bleeding locally in the area where the local anesthetic is deposited. Second, vasoconstrictors can also slow down systemic absorption. How? When the blood vessels are constricted, then local anesthetics would be distributed more slowly into the systemic circulation. That's why, in effect, or technically speaking, you are prolonging the effect of the local anesthetic. So, again, vasoconstrictors like epinephrine and levonorepinephrine are added to the local anesthetics. For what reason? To reduce bleeding and to slow down systemic absorption. So once the systemic absorption is slowed down, then basically the effect is prolonging the action of your local anesthetics. Now, epinephrine, 1 is to 100,000 epinephrine is equivalent to 1 is to 20,000 levonorepinephrine. Okay, so these are the common amounts of epi and levonorepinephrine that we see in cartridges. Epinephrine as vasoconstrictors would have alpha 1, 2, beta 1, and beta 2 as receptors in the body. That's why epi has effect in heart rate and in blood pressure, because the receptors for epinephrine would cover alpha 1, 2, beta 1, and beta 2. However, levonorepinephrine receptors are just basically alpha 1 and alpha 2. Okay, so these are just some basic things regarding your local anesthetics. Now, the local anesthetic efficacy, this is what I've been saying earlier regarding your local anesthetics. So we said that local anesthetics has a mix of charged and uncharged molecules. Okay, so this is your local anesthetics. This is the ideal. Okay, this is the ideal concentration of the local anesthetics. There's 50% that's charged and 50% that is uncharged. Okay, now when this local anesthetic is injected in a tissue with a pH of 7.4, what happens is that there would be a greater number of unionized molecule in your local anesthetic because of the difference in the pH. Okay, remember we said our local anesthetics are weak bases. Okay, so weak bases injected into tissue that has a pH of 7.4, you'd have more unionized molecule. And these unionized molecules are the ones binding to your sodium ion channels. Okay? Because more unionized molecules would bind to your sodium ion channels, then you would end up getting a more profound anesthesia. Now, what happens when there's an infection? So if there's an infection, your local anesthetic, so this is your local anesthetic with its ideal charge, like 50-50, 50 charge and 50 uncharged molecules. Once you inject it in an infected site, having a pH of 3.4, so basically a pH of 3.4 is very acidic, right? So what happens here is that instead of having more uncharged molecule, you'd end up with more positively charged molecules. And these positively charged molecules, they do not bind to your sodium ion channels. So what are you going to end up with? You're going to end up with a lesser amount of negatively charged ions that would bind to your sodium ion channels. Since you have a lesser amount of molecules binding to your sodium ion channels, then you'd end up with what? A lesser anesthetic effect. So this is why in the presence of infection, local anesthetics do not really work as good. Okay? It's a matter of having lesser uncharged molecules that's available to bind to your sodium ion channels. Okay? So I hope that is clear. All right. Now, when we talk about local anesthetics, I'd just like to lay out some definitions with regards to different terms. Okay, so here we have the term potency, onset, and duration. So how do they differ? Potency basically is defined as the amount needed to produce an effect. Okay, amount needed to produce an effect. So when we say that a substance is potent, very potent, it just means that you need a lesser amount of it in order to produce an effect. Okay, so that's potency. Now, potency is determined by lipid solubility, or the ability of the local anesthetic to be soluble and to cross membrane barriers, which is basically lipid. Okay, so potency is determined by lipid solubility. So how do we interpret this? The higher the lipid solubility of your local anesthetic, it means it's more potent because it is able to penetrate those barriers, those membrane barriers. And so, since it is more lipid soluble, it means it's more potent, then it means you need less amount of that item to produce an effect, to produce an anesthetic effect. Okay, so that's basically potency. Okay, now onset. When we talk about onset, it is defined as the beginning of an action, or if we can say it in more plainly, how soon would it take effect? Okay, that's onset. Onset. When does it begin? Onset. Okay, now onset is determined by the dissociation constant, or your pKa. Okay, so I know this is like a scientific term, but then what is pKa? pKa is simply the pH at which the local anesthetic is 50% ionized and 50% unionized. Okay, so pKa is 50-50. It is the pH at which your local anesthetic is 50% ionized and 50% unionized. So this is what I was talking about earlier, like this is your ideal local anesthetic agent, where the pKa or the pH of that local anesthetic, you have 50% ionized and 50% unionized. Okay. Generally speaking, the pKa of your local anesthetics is greater than 7.4. Okay. Now, how do we interpret this? It just means that the closer the pKa of the local anesthetic to the tissue pH, the faster the onset. Again, onset, beginning of action, how soon it takes effect. Okay? So the closer the pKa of the local anesthetic to the tissue pH of 7.4, the faster the onset. So lower pKa, closer to 7.4, faster onset. Okay, that's what it means. Now, next term is duration. Duration basically pertains to the length of action. It is determined by the protein binding capacity of your local anesthetic. It is determined by lipophilicity, or lipophilicity is also your lipid solubility. It's dependent on dosage, or how much of the local anesthetic did you inject. It depends on vascularity. Vascularity, we're talking about blood vessels. So how much blood vessels are in the area. And duration will also depend on the presence of vasoconstrictors. Okay. So how do we interpret these things? When we talk about protein binding capacity, it is the ability of your local anesthetic to bind to protein molecules and insert themselves in the membrane. Okay. So local anesthetics with high protein binding capacity would also mean that they are highly lipid soluble. So these two go hand in hand. If there's an increase in protein binding capacity, then chances of it crossing your membrane barrier is also great. So high protein binding capacity, high lipid solubility, it means longer duration of your anesthetic. It means it can work for hours, or it can work for greater amount of time compared to those with lesser protein binding capacity. Okay. Same with dosage. Of course, the more you put in, the more anesthetic agents you put in, the higher dosage that you give, then of course the duration would be longer. Now, vascularity, vascularity on the other hand, this is the reverse. Okay. If the area where you injected the local anesthetic is highly vascularized, meaning there's a lot of blood vessels around the area, then that would make the duration of your local anesthetic short. Why? Because once you inject the local anesthetic in one area, what happens is it would spread. Some of it would go to your, would go across your nerve membranes, but some of it would also go closer to your blood vessels. And once they enter the blood vessels, then it would spread throughout the system, and so the duration of your local anesthetic is actually cut short. Now, presence of vasoconstrictor. We said earlier that the presence of vasoconstrictors would actually prolong the effect of your anesthetic. So basically, presence of vasoconstrictor would increase duration of your local anesthetic. Okay, so these are terms that you have to take note of: potency, onset, and duration. You'll find out more later, okay, why these things are important. Now, basic things about your local anesthetics. Local anesthetics, this is the main structure, of local anesthetics. You have three main components. You have an aromatic group, you have either an ester or an amide linkage, and you have your amine group. So the aromatic group right here, it's responsible for lipophilicity, or lipid loving. your ester and your amide linkage right here. This is the one responsible for us identifying whether an anesthetic is an ester or an amide. It's dependent on this second part. And then the amine group right here. So the amine group, so this is usually a tertiary amine. And this is responsible for hydrophilicity, or the water-loving part of your local anesthetic. Now, we said that for anesthetics, you have two major groups. You have your esters and your amides. And this is determined by the second component discussed earlier. Now, what's the basic difference between esters and amides? Esters are metabolized by serum or plasma esterases. Okay, so that's where your esters are metabolized. They pose a higher risk of causing allergies. That's why you would encounter people with allergies to your local anesthetics. It's basically they're allergic to esters. Examples of esters are your cocaine, your procaine, your tetracaine, and your benzocaine. All right? Now, amides, on the other hand, they are metabolized in the liver. Okay? Esters earlier on, they're metabolized by serum or plasma esterases, meaning in the blood. Okay. Amides, on the other hand, are metabolized in the liver by your cytochrome P450. So they're the ones that degrade your amides. Now, amides are safer and more stable than your esters. Examples of amides are lidocaine, articaine, bupivacaine, mepivacaine, and then your prilocaine. One thing to remember it by, esters do not contain an I in their name before cane. So if you would notice, cocaine, procaine, tetracaine, benzocaine, no I. So esters, no I. While for the amides, you have lidocaine, articaine, bupivacaine, mepivacaine, and then your prilocaine. Okay? So esters, no I. One way to help you guys memorize. Esters, no I. Even in the word ester, you don't see an I. So esters, no I. Cocaine, procaine, tetracaine, and benzocaine. One thing that we know now regarding esters is that this is basically not used in dentistry anymore except for benzocaine. Okay? So benzocaine is the one that's left in used in dentistry, but as topical. So most of topical agents in dentistry is made of benzocaine. All right. So, but nonetheless, under esters you have your cocaine, procaine, tetracaine, and benzocaine. Cocaine is the first local anesthetic agent discovered. However, it's not used in dentistry because it's very addictive and toxic. Now, procaine, or commonly known as novocaine, it's an analog of cocaine. It has a short duration of action. It has very high allergenicity, but it is also not available anymore. Although a lot of people would still call local anesthetics as novocaine because it became popular way back when. Okay? Now, tetracaine. Tetracaine is used in dentistry but only in compounded topical ANS. Compounded topical ANS. What does that mean? Compounded meaning it is mixed with other agents such as your benzocaine. Okay? So, tetracaine used in topical anesthetics but not as a standalone. It is mixed with other agents. Now, benzocaine, this is used as a topical, still in dentistry. It has a rapid onset. One thing that you have to take note of regarding benzocaine is that it does not have an amino terminus. It does not have any secondary or tertiary amine group. So basically, it has your ring and it has your ester linkage. That's it. No amine group at the end. Another thing to take note of regarding benzocaine, it can cause methemoglobinemia. Okay? Now, amides. Esters no I, amides with I. Amides has an I. Now, these things you have to take note of because these are commonly used in dentistry even up to present. So, we have lidocaine or brand name silocaine. You have your prilocaine or sitnest. You have bupivacaine or marcaine. Mepivacaine marketed as carbocaine. Now, among these four, lidocaine is still the gold standard for local anesthetics. Okay? Lidocaine, it comes either in a 2% plain or 2% with epinephrine. 2% lidocaine with epinephrine. Either 1:50,000 epinephrine or 1:100,000 epinephrine. Okay? Lidocaine has a topical form. It is the safest for children and for pregnant women. The pKa is 7.8. Again, what was mentioned regarding pKa, pKa has something to do with the onset. The lower the pKa, the faster the onset of your anesthetic. Okay? So lidocaine, gold standard. It comes in 2%, either plain or with epi. Alright? Next stop is prilocaine or your Citinest. Prilocaine or Citinest, one thing to take note of with this is that it reduces oxygen carrying capacity of the blood, so it is contraindicated for patients with blood disorders, such as your sickle cell anemia or patients with cardiac or respiratory failure. Now, prilocaine is metabolized to O-toluidine. Okay? O-toluidine, which can eventually cause methemoglobinemia. So, when it comes to methemoglobinemia, you have two things. You have your benzocaine and you have your prilocaine. However, it is prilocaine that is oxidized to O-toluidine. Okay? Which can cause you your methemoglobinemia. Just take note of these because these things can be asked, in your board exams. Now, prilocaine comes either in 4% concentrations, 4% plain, or 4% with epinephrine, 1:200,000 epinephrine. The pKa of your prilocaine is 7.8%. Okay? Now, next is your bupivacaine, or commonly known as your Marcaine or marketed as Marcaine. Bupivacaine has the greatest lipid solubility and the greatest protein binding capacity amongst all your local anesthetics. So what does that mean? We said earlier, if something has a very good lipid solubility, something has a very good protein binding capacity, then you would end up with what? The longest duration of anesthetic. So if you're working on long procedures, then you can count on bupivacaine to take effect for longer periods of time compared to lido, prilo, and mepivacaine. Okay? It has the highest, however, it may have the greatest lipid solubility and protein binding capacity. However, it has the highest pKa of 8.1. What does that mean? Again, pKa has something to do with onset. The higher the pKa, the slower the onset. So, it has the longest duration, however, it has the slowest onset. Okay? Now, this affects the CV system the most, your bupivacaine, well, because of its, long duration. Now, bupivacaine, it is marketed in 0.5% with epinephrine at 1:200,000. And then lastly, the mepivacaine, or the carbocaine, it is the least vasodilator among all your local anesthetics. We said earlier that generally speaking, local anesthetics are vasodilators. Okay? So if it comes plain, then they don't have any vasoconstrictors. So they're all vasodilators in general. However, mepivacaine or your carbocaine is the least vasodilator. That is why it is the option when the epinephrine is contraindicated on the patient. Okay? Now, mepivacaine or your carbocaine is comparable to your lidocaine. It is dispensed as 3% plain or 2% with levonorepinephrine, 1:20,000. Okay? Take note, mepivacaine is the only anesthetic that is dispensed in two different concentrations. Either it comes as a 3% plain or 2% with levonorepinephrine at 1:20,000. Okay. Now, mepivacaine, it has a pKa of 7.7. So if you compare all four, this has the lowest pKa. So this has the fastest onset. However, it may have the fastest onset, but it has the shortest duration. So this is good for short procedures. Now, if you would notice, like lidocaine comes in 2%, prilocaine comes in 4%, bupivacaine comes in 0.5%, mepivacaine either 3% or 2%. What do these percentage mean? The percentages, they actually are related to the potency. Okay, so the percentage, they are related to potency. So if you would compare all the four, lido, prilo, bupi, and mepivacaine, bupivacaine has 0.5%. There's 0.5% bupivacaine in one cartridge. So what does that tell you? Among the four, this is the most potent. This is the most potent anesthetic. That's why you only need a small amount of it in order for it to work. Okay? So these are the four amides that is commonly used in dentistry today. Now, there is one special local anesthetic that is still in use today, and this is your articaine. Why is it special? Because it is an amide with an ester linkage. So it exists in both ester and amide form. Okay, so again, articaine, or marketed as septocaine or ultracaine, it contains both ester and amide linkages. So it's metabolized both in the serum and in the liver because it's both an ester and an amide. Again, esters are metabolized in the serum while amides are metabolized in the liver. So since it's dual, this is the best choice for patients with liver disease. Why? Because it can go easy on your liver because some of it would be metabolized in your serum. Okay? That may be a plus factor, but it also has its con. What is the negative factor related to it? Because it has an ester side chain, it is also rapidly inactivated via hydrolysis of your ester in your blood. That's why it has the shortest half-life. Amongst all your anesthetic agents, articaine or your septocaine has the shortest half-life. Okay? And articaine, potency-wise, well, it's 4%. With epi, 1:100,000 or 1:200,000. Another thing that makes articaine special is among all your local anesthetics, it's the only one that's dispensed in 1.7 ml carpules. All of your other local anesthetics, your amides, they're all dispensed in, this is compared to 1.8 ml. Okay, so it's usually 1.8 except for articaine. All right, next. Let's take a look at the most common local anesthetic that we use. So 2% lidocaine, 2% lidocaine with 1:100,000 epinephrine, 1 ml cartridge. This is the most common one that we use. How much lido is in there, how much epi is in there, then it's here. So 2% basically is 2 grams per 100 ml. So if you do your, if you want to find out how much lidocaine is in there, then you do your 2 grams per 100 ml is equal to X grams over 1.8 ml. And then you do your cross multiplication, and then you'd end up with 0.036 grams per 1.8 ml or 36 milligrams per 1.8 ml. So in one cartridge of 2% lido with 1:100 epi, you have 36 milligrams of lidocaine. For the epinephrine, 1:1 is 1 gram per ml. 1:100,000 is basically 0.01 milligram per ml, per 1 ml. So 0.01 milligram per ml, x milligram per 1.8 ml, you do your cross multiplication again, then you'd end up with 0.018 milligrams per 1.8 ml, or 18 micrograms per 1.8 ml. So in one cartridge, you have 36 milligrams Lido, and you have 18 micrograms of epinephrine. Okay? So basically, do your math. If you have 2 cartridges of 2% Lido with 1:100,000 epi, then, you just multiply it by 2. 36 times 2, that would give you 72 milligrams of lidocaine, and then 36 micrograms of epinephrine. Okay? Now, have you noticed this? I don't know if you have, but when you look at cartridges, they do have different colored bands. Okay? Now, with the different colored bands, it actually gives you different concentrations or different types of anesthetic. So, what am I trying to say? The bands would give you an idea as to what type of anesthetic it is. Okay? So, it's just a clue that would give you, in case you're not really paying attention, you can just know the band color and know what type of anesthetic it is. Now, moving on. Some adverse effects of local anesthetics. So basically, allergy is common. Okay? This is especially common in esters, and this is also common in local anesthetics with vasoconstrictors. Why? Because the allergic component, or the components that would give allergy, would be the metabisulfite, which is a preservative. So metabisulfite prevents oxidation of your vasoconstrictors. So basically, the one that's more allergenic would be those cartridges with vasoconstrictors. Okay? So for allergy, it can be caused by metabisulfite, or it can also be caused by your methylparaben. Methylparaben. But this was way back then, This is also a preservative, methylparaben. Okay? Now, other adverse effects, well, mild to moderate toxicity. Well, what happens to the patient? They become more talkative, apprehensive, more excited, But for severe toxicities, of course, you would expect seizures, respiratory distress, coma, or even death. So these are just some adverse effects of your local anesthetics. Now, other considerations in using local anesthetics. It's safest for pregnant women and children. The safest for pregnant women and children it's basically lidocaine. Okay? Now, for patients with cardiovascular disease, one thing to take note of is we should limit epi to 40 micrograms per visit. Why? Because studies have shown that if they're given beyond 40 micrograms of epi, they would show some elevation in their vital signs. Okay? So 40 micrograms of epi would basically be what? We said earlier that one cartridge has 18 micrograms. One cartridge of 2% lidocaine with 1:100,000 epinephrine, that's 18 micrograms. So if the limit is 40 micrograms, then basically this is just 2 cartridges, right? Because 2 cartridges would be 36 micrograms. So you're bordering to your limit of 40. Okay? Now, the usual maximum recommended dose, common, no? For all anesthetics is 4.4 milligrams per kilogram. So those are the different considerations that we have regarding your local anesthetics. And then some drug-to-drug interactions. something that we have to take note of when anesthetizing patients, or even before we deposit any anesthetic agents, we have to find out if they are taking any of the following drugs. So if the patient has some depression problems and they're taking TCAs or PCAs, your tricyclic antidepressants or your polycyclic antidepressants, then it is better to use anesthetics without epi, such as your carbocaine. Okay? Why? Because they have increased sensitivity to epinephrine. Now, in case the patient is taking any non-specific beta blockers, such as your propranolol and your Inderal, what happens is that the anesthetic agent would enhance the peripheral alpha adrenergic effects with beta-2 blockade. So, remember earlier we talked about the two different vasoconstrictors, epi and levonorepinephrine, and we said that receptors for epi would be alpha 1, 2, beta 1, beta 2. And receptors for levonorepinephrine would be alpha 1 and alpha 2 only, no beta. So what would happen if the patient is taking propranolol or Inderal and then you give them LAs with vasoconstrictors? Well, basically, epi would increase the blood pressure. Epi and levonorepinephrine would increase the blood pressure of the patient. Now, non-specific beta blockers enhance peripheral alpha, so it means it would increase blood pressure, but then it blocks beta 2. So for levonorepinephrine, that's not a problem, but for epi, beta 2 blockage would mean that the patient would have a decrease in heart rate because beta 2 is blocked. So decrease in heart rate. So what is the end result? The patient would actually have an increase in blood pressure without any accompanying tachycardia. So the downside of it is the patient would have an increase in blood pressure, but then they don't feel it because their heart rate is normal. So that's why, we have to be careful in administering local anesthetics. So it's not all the time that increase in blood pressure would be accompanied by increase in heart rate. Okay? Another thing to consider, procaine, it's metabolized to PABA or your para-aminobenzoic acid, and it would inhibit the action of your sulfonamides. Sulfonamides are antimicrobials, okay, that is competitive to your PABA, okay, but this is not really concerned if you're not using procaine or novocaine anymore, all right? And then cimetidine increases plasma levels of lidocaine, which can lead to toxicity. Now, cimetidine, if you're not familiar with it, cimetidine are heartburn medicine, okay? So, if they're taking cimetidine for heartburn issues, for GERD or your gastroesophageal reflux disorders, then if you use local anesthetic with lidocaine, then there would be increase in their plasma levels. All right, and then local anesthetics may also antagonize acetylcholinesterase inhibitors in patients with myasthenia gravis. Okay, so just take note that whenever we use our local anesthetics, there can be contraindications. All right, that is why if your patient has a lot of like items in their medical history, then it is safe, or it's better for us to use local anesthetics without epi. And the best choice for that would be the least vasodilator of them all, and that is your carbocaine. All right, but then again, gold standard for local anesthetics is lidocaine. 2% lidocaine with 1:100,000 epinephrine. Okay, so that ends our topic for today, and hopefully you learned. So once again, this is Crush My Dental Boards, local anesthetics in dentistry. Okay.